Hi, everyone. Thank you for joining. We're really happy to have you here today. I just wanted to remind people the Learning Collaborative was brought together because our partners that we work with for clinician and staff peer support were really interested in more learning as we go on. So we've been fortunate enough to have a couple of speakers and that have been really influential, and we have another one today. So we'll be introducing him shortly, but I just wanted to let you know that the presentation is being recorded. There will be a video available after. We will also send the slides after the, thank you, Whitney, after the presentation, probably tomorrow, once we get the recording and everything. We will have a question and answer period during this, so you can, at that time, you can raise your hand and we will answer that way. But you can also, while the presentation's going on, put your questions in the chat box, and we will alternate between what was in the chat box and the raised hands at the end of the presentation. So I'm going to turn it over to our executive director for the Betsy Lehman Center, and that is Barbara Fain. Thanks, Barbara.
Thanks very much, Linda, and welcome everyone. So I have the honor of introducing our speaker today, Dr. Michael Gustafson. Dr. Gustafson has been a senior healthcare executive for 3 decades. His career has been dedicated to transforming healthcare delivery in the US and driving improvement in quality, safety, equity, and experience for both patients and caregivers. His many passions include healthcare strategy, clinical innovation, organizational culture change, and leadership development. Dr. Gustafson currently serves as CEO of the Schwartz Center for Compassionate Healthcare, which is a Boston-based international nonprofit whose mission is to keep compassion in the heart of healthcare through programs, education, and advocacy. Before then, he was president of UMass Memorial Medical Center, which he was able to advance as a national leader in clinical quality and safety, patient experience, and caregiver engagement. We are thrilled, absolutely thrilled, to have Dr. Gustafson with us today to share his thoughts on how organizations can be transformed through the power of compassion. And so with that, let me turn it over to Dr. Gustafson.
Hi, Barbara. I'm just going to get my slides set here. I think we're good. So can you guys hear me okay? So Linda and Barbara, thank you so much, and to the team at the Betsy Lehman Center for asking me to speak today. I really look forward to sharing thoughts about compassion over the next hour and having a great discussion about this. I hope to cover today just a brief overview of the Schwartz Center. We're celebrating our 30th anniversary. It's a very exciting time for us. And then I want to dive into exactly what do we mean when we say compassion? Why does it matter? And if it matters, can it actually be increased or improved? And then share some thoughts around how compassion can actually help transform organizations. So as many of you know, since you're in the Massachusetts area, the Schwartz Center has a long history. We were founded in 1995, unfortunately based on a tragedy. So Ken Schwartz was a healthcare attorney in Boston, was diagnosed with terminal lung cancer, had a treatment for about 9 months at the MGH Cancer Center. But several things happened. One is that Ken wrote about his experience in the Boston Globe magazine, and it was a really compelling description of not just the clinical care that he got, which was amazing, but the human and compassionate care that he received. And Ken was worried that with all the forces coming at healthcare in the 90s, that providers wouldn't be able to sustain that type of compassion. So he and his family and friends worked hard to establish the Schwartz Center, and it grew from Massachusetts to New England, to national and international organization. I like sharing several quotes from Ken, but this one I picked to start, which is, if I have learned anything, it is that we never know when, how, or whom a serious illness will strike. If and when it does, each one of us wants not simply the best care for our body, but for our whole being. It's really the essence of compassion. As I said, we're celebrating our 30th anniversary, so we've had a great opportunity to revalidate our mission, our strategic plan. Our mission is to really partner with healthcare organizations, and that is to advance compassion for patients, their care teams, and that sacred healing relationship. And our vision is truly to be a global leader in advancing that compassion. In our most recent strategic plan and vision for the next 5 to 10 years, we have really 3 focus areas. The first is to expand the reach of our Schwartz Rounds program, and I'll explain a little bit how we want to go into new sectors and additional parts of the world. Second, we have this amazing community of compassion champions, folks that are engaged with our programs throughout the world. And our goal is to increasingly support them with education, networking, and recognition. And finally, developing new programs as the needs evolve in healthcare and new partnerships. And I'll touch a little bit on that. Our programs and essentially consist of 2 signature programs, our Schwartz Rounds and Stress First Aid. I'll describe both of those in a little bit more detail. Our education is accomplished through Compassion in Action webinars like this webinar series, and a variety of trainings and workshops for our compassion leaders. Networking is a really big thing that we do, which is bringing all the folks doing this work together on topics like rounds effectiveness, and then recognition programs like our National Compassionate Caregiver Award, and historically our Impact Honors, which is honored and called out innovative compassion programs. So what is compassion? I like to always start with just the definition of that word because it means lots of different things to different people. I like to think of compassion as sitting on a spectrum of caring, if you will. So often we start with sympathy, which can be described as the feeling of pity or sorrow for someone else's misfortune. Kind of the next level up of engagement would be empathy, which is recognizing and feeling somebody else's pain or feeling somebody else's joy. And in the literature, there's really 2 types of empathy: cognitive, which is kind of the intellectual resonance and understanding somebody else's situation. But there's also an affective empathy, which is actually feeling and resonating the emotions. And then compassion, we think of as essentially empathy, adding to that action to relieve the distress and suffering. And typically we think about compassion for patients, but increasingly we also want to think about compassion for providers. And it's not just compassion as we might think about it at the end of life, but it's compassion for any form of mental or physical distress, anxiety, anger, grief, pain. And of course, all of those emotions occur throughout life, throughout episodes of care, chronic disease, or hospitalization. So it's really relevant across the spectrum. So I'm not a neurologist or a neuroscientist, but I will share a couple slides about what is known about empathy and compassion in terms of the neurologic basis. I find this really amazing. In the last couple of decades, there's just been an incredible depth of understanding, like what's the neuronal and hormonal basis for how this works. So there's, I think, at least 3 key points. First, we all have the capacity and the hardwiring for empathy and compassion. That's important because, historically, some folks have thought, well, certain people are compassionate and others aren't, just the way that they're born, raised, or hardwired. Well, I think the neuroscience would suggest otherwise, right? Those pathways are mediated by core neural networks that exist in essentially every brain. We also know that compassion can be taught. With the advancement of functional MRI studies in the last few decades, we actually know that compassion training can light up these areas of the brain. And further, which I think is really amazing, we know that the brain, like a muscle, can actually be strengthened. And with longitudinal compassion or empathy training, we can actually see thickening of the cortical gray matter. So I think it's we have a strong basis to which to build this work. The pathways for empathy and compassion are slightly different. Empathy for others' pain actually activates a region of the brain that's associated with direct pain experience, while on the other hand, compassion activates other areas of the brain that are associated with positive and reward. So you can imagine that those are the more self-soothing aspects that would counter kind of the negative aspects of empathy. Why is that relevant? Well, I like to think about it as applied to burnout. So, one of the definitions for burnout or scenarios is burnout occurs when you know what a patient needs, but you're consistently unable to meet those needs, right? So in a very simplistic way, you could see that the empathy pathway is activated, the pain, but you don't have the corresponding positive offsetting pathways. And then before we leave this section, I always just like to address other words or other philosophies of care, which I think are really important. Each of these areas have their own body of literature, research, interventions that are really important. And we feel like each of these help contribute and lay the foundation for effective compassionate care. So that includes a literature around kindness, humanism, holistic care, which is essentially seeing the full person, the whole person, the importance of equity and inclusion, empathy, patient empowerment, and patient-centered care. So the next question is, why does any of this matter? Why does compassion matter in the year 2025? Fortunately, I'm happy to report that we have an amazing body of evidence that suggests that compassion is not just a nice to have, it's not just the emotive part of the experience, but it actually can impact hardcore clinical outcomes, and in some cases, survival. I think the best summary of this was done by Dr. Steve Tresiak in Compassionomics. In that book, there's close to 450 peer-reviewed clinical articles that are cited, illustrating what I was just talking about. And Steve refers essentially to this as documenting the science of compassion, right? How compassion actually changes and modulates outcomes. So for patients, it means a whole variety of things. It can mean reduced pain and disability from various conditions or injuries, less symptoms, both psychologic and physical symptoms in cancer patients, less PTSD in trauma patients, improved adherence with medication and treatment protocols, improved chronic disease outcomes, including a whole spectrum of osteoarthritis to asthma to diabetes, and then in general, literature around positive patient experiences. For providers, on the other hand, compassion itself can provide a sense of positive emotions, a sense of reward and fulfillment, affiliation and connection, improve professional quality of life, reduce turnover, and improve productivity. That's really important because of the connection of those things to burnout. And I really like to use this schematic that our former CMO, Dr. Beth Long, created and published in 2019, which puts compassion next to burnout. Just try to show the connection. Compassion is characterized by emotional engagement, affiliation and connection, and a sense of actually helping others and sense of reward. And you can see how that contrasts to the three traditional components of burnout, which is described as emotional exhaustion, depersonalization or detachment, and a low sense of accomplishment. So there are several different relationships here that could be bidirectional. First of all, you can imagine if somebody is burned out, they're less able to deliver compassion. But we also strongly feel, and the evidence would suggest that compassion itself is an antidote to burnout. In this study, Beth published that compassion-related behaviors by nurses and physicians were inversely correlated with their emotional exhaustion and depersonalization and with their lack of perceived organizational support. So the less that the providers feel that they were supported, the more burnout they were, and the less ability to deliver compassion, an unfortunate negative cycle. And so why does this matter? I just wanted to remind folks on this call, because it's really relevant to patient safety, that if compassion can be an antidote to burnout, burnout is clearly associated with multiple patient safety issues. Literature in the last 6 or 7 years have all demonstrated that burnout's associated with higher turnover, which leads to less continuity and more handoffs, increased patient safety incidents, med errors, malpractice suits, decreased patient satisfaction, and flawed or impaired diagnostic processes. So pulling all of this together, what I'd like to present today is the theory of the case, if you will, using a legal term, for compassion. And so starting here on the left, we feel like caring and support for the care team, which is a big focus of healthcare organizations now, is incredibly important. That care team members will then feel more compassionate and less burned out. Patients will then experience more compassion and support. And there are two key sets of outcomes. Patients will actually have better health outcomes, including morbidity and mortality indications, and healthcare workers, teams, and the organizations will thrive. So summarizing all of that literature and trying to get into one infographic for easy reference, you can think about all the things that compassion has been demonstrated to increase, which is better patient physical and mental health, better patient satisfaction and loyalty, improved healthcare worker physical and mental health, definitely increased teamwork and communication, an improvement of organizational culture and engagement, and operating revenues and margins. And on the other hand, decreasing utilization of unnecessary resources and services, med errors, claims, burnout, turnover, lost physician revenue, and all of the costs associated with vacancies and overtime, et cetera. Probably the number one question we get, though, is how do you take all of this and turn it into a business case, right? What is the return on investment, the ROI for compassion? It's probably our number one question or discussion with healthcare leaders. So the next slide basically just tries to break that down, right? How I would be doing this if I were in a healthcare institution still. You want to think about all the ways that these investments decrease cost and increase revenue. Healthcare is at least 60% labor cost, so that's where the biggest return will be. By reducing burnout, which as you can see costs the US close to $5 billion a year at least, that by reducing burnout, that will reduce turnover and vacancies. That's the biggest driver of very expensive coverage and replacement costs. You can see the average numbers here for just replacing one provider, and reduce mental physical health cost for providers. Reduce utilization of unnecessary tests, decrease ICU utilization and readmissions. That's really important in a risk-based or value-based environment, and reduced medical errors. On a revenue side, evidence that increasing these components of compassion for patients will increase patient loyalty and therefore facilitate volume growth, and good evidence around improved caregiver productivity and retention. So hopefully I've convinced you that compassion does matter. Then the next question is, how can compassion actually be improved? And I would start by saying that probably the area with the longest history is in communication training or improvement between individual providers and patients. The work on that began in the 1970s, has continued for about 50 years. And there's a huge body of literature in a whole field that has demonstrated that with the right interventions, communication between a patient and providers can actually be improved with significant outcomes. Today, what I'd like to do is to walk through a case study with our Schwartz rounds and share the evidence of this intervention on compassion. So first of all, what are Schwartz rounds? Hopefully many of you have personally experienced a Schwartz rounds in your current or previous organizations. But Schwartz rounds is it's a regular open forum held by institutions, very multidisciplinary, and the primary focus is to talk about the psychosocial and the emotional aspects of caregiving, with a focus on both the challenges and the joys and the rewards of work. This is not a clinical case discussion. It's about the emotional human aspects of caregiving. Every session is organized either around one compelling patient story that's told by several different perspectives, or it's a theme, a patient or caregiver theme that's illustrated with multiple patient stories. It's facilitated by a Schwartz-trained facilitator, ideally incorporating trauma-informed care principles. It's clinical and non-clinical in terms of the participation, which is unique in healthcare. Typically is an hour long. Historically was always in person, but increasingly is either hybrid or virtual at our various institutions. And historically it's been organization rounds, but increasingly we're seeing folks adapt rounds for team-based settings. So this can be unique groups like learners or leaders, or taking the rounds to a clinical unit or to a department to have a similar type of discussion. Just to give you a flavor of the types of themes or topics, this is out of our national list over the last several months, just to give you a sample. You can see themes range from the patients that they'll never forget, so inspiring patient episodes, to pulling topics right off the headlines. So workplace violence, homelessness, immigrant issues, the stress of financial pressures on hospital, dealing with loss and grief, the power of small gestures, exquisite moments of compassion, and then gratitude and joy. I really, it's good to have that as a mix of the menu of topics for each institutions. Things like finding joy and awe in our work or the power of humor. So fortunately, we have over ourselves and many others have studied the impact of Schwartz rounds. There are over 100 articles published across 25 years and across now 5 or 6 countries, multiple settings, inpatient, outpatient, community-based, multiple disciplines and roles, et cetera. And these are the consistent benefits of doing this type of reflective discussion. And they fall into 4 categories. First, what's the benefit for actual patient care? Well, we know from our studies that participants report that they have increased compassion and empathy. They've improved insights into patient needs and concerns, and improved sensitivity to the impact of the illness on the patient and family, and in general, better patient satisfaction. For the attendees in the sessions, we know that there's a significant reduction in psychological distress. There's renewed passion and commitment. There's a reduced mental health stigma, which is really important, decreased isolation, and reduced moral distress. One of the things I think is really interesting is the impact on care teams. Because this is multidisciplinary, it's non-hierarchical, it has participants from surgeons to nurses, therapists, to frontline staff, to housekeepers. It helps to break down silos, and it helps to build team and communication, as well as understanding each other's roles and perspectives on the team. So incredible benefits for care teams, which of course is a really important patient safety component. And then finally, impact on the entities. And we know that it helps in general foster positive and supportive learning environments within institutions. It really helps to break down silos between departments. It's a great opportunity for visible leadership support and mentoring. Sometimes the discussions can lead to changes in policies and practices outside of that setting, and what we refer to as the ripple effects on the culture throughout the organization. I wanted to share just 2 specific pieces of data. This is from our original seminal study by Dr. Lown in 2010. but it shows on our surveys that we continue to do after every single session that the participants report these various aspects of improved insights, focus on their patients' lives, and the ability to deliver more compassionate care. And what's really striking in this study, which I love, is the dose effect. So the more participation in Schwartz rounds for each individual, the greater the reported benefit. There were similar impacts in this same study on teamwork questions, as well as individual resilience and mental health. There's one other study which I like to cite, which was done by Dr. Jill Mabin and her colleague Jeremy Dawson, done in the United Kingdom after the UK and Ireland had adopted Schwartz rounds. Right now, there are about 200 facilities in those countries that are very aggressively running Schwartz rounds. And Joe was able to do a longitudinal study of round attendees versus non-attendees for a comparison group, and was able to show this marked 50% reduction in reported psychological distress, and even more in terms of severe conditions that might require mental health intervention. Dr. Mabin and Jeremy Dawson are actually going to be doing a webinar on their experience in the UK and all of the research they've done in November. So if you want to learn more about that, just check that out. And then the future of rounds for us, historically, we've been doing most of these rounds in acute care settings. We want to, as I described, reach out to more people within the hospitals, team-based rounds, leadership rounds, rounds with learners. In the UK, they are doing rounds within multidisciplinary higher education learning institutions with medical students, nursing students, pharmacists, therapists, et cetera, doing multiple rounds during their learning curriculum. It's really an amazing kind of evolution to reach people before they get into the clinical practice setting. And then there's tremendous opportunity to expand across the rest of healthcare. And these are just a few examples where we've already done some work supporting, for example, social workers, case managers, and the insurance company, who have an incredibly tough job of managing that interface between the patient and the providers and the insurance company, school nurses, and all these others that are listed. I wanted to spend just a minute on our other program, which is Stress First Aid. This is really relevant to the peer support effort of the Betsy Lehman Center. So as many of you know, Stress First Aid is a program that was first created at the National Center for PTSD and was intended for military and first responders. We were able to partner with Dr. Patricia Watson to adapt that for a healthcare specific version in the first year of the pandemic. And for the last 4 years, we've been working with partner institutions to roll this out. We have about 100 institutions that we've worked with. Almost invariably, there's been a very positive uptake and reaction to introducing this within staff. It is a very flexible model, meaning that it can be, for example, introduced just for peer support, trained peer supporters. It can be rolled out for managers or leaders to support their staff, or it can be rolled out across all frontline staff in an institution. The main key part of Stress First Aid is it's intended to be a psychological first aid, and it's self-care for each person, as well as watching out for the providers that are next to you. So that ongoing day-to-day support for others around you. These are two of the key frameworks in our adaptation of Stress First Aid. Importantly, there's a stress continuum, which ranges in this thermometer from red to green. In the best case scenario, this discussion gets embedded into a daily nursing unit huddle. How are we doing today as a unit? Are we red or orange? Or how is each individual doing today? Are we doing am I a yellow or an orange? And then being able to hear and respond to that appropriately, or beginning department meetings or administrative meetings with the same discussion. On the right hand is essentially the intervention side. There's two key components of checking in with colleagues and then coordinating the response or the resources. And then there's a menu of things to choose from, around 5 domains. So creating safety, calm, connection, self-efficacy, and sense of hope. I just wanted to show one example of how customizable this is. Recently, Hartford Healthcare presented to our board of trustees the work that they've been doing with us over the last year or two. You can see that they've embedded these concepts into pocket cards or ID badges to make this very accessible to frontline staff. And they've embedded this in their overall well-being program as a system across their 7 hospitals. And they see this and Schwartz rounds as 2 key components of their 3-level pyramid. And then finally, how can we take all of this and combine it in a way that compassion can actually help transform organizations and address some of the concerns that are facing institutions today? So returning to the case for compassion, I'm just reminding folks that we feel like it's really important for care team members to be able to feel supported and to be able to deliver compassionate care. Patients will then experience more compassion and support. And as I hopefully have conveyed, that will drive very real, tangible, better patient outcomes and better frontline caregiver outcomes and care team health. That relationship between the patients and the healthcare team is really the essential nexus, right? That's the healing relationship. And that is really the core of what we are calling our Schwartz Compassionate Care Model. This is our schematic. At the center of this model, in the heart of the compassion is the patients, the care teams, and that healing relationship. There are 2 domains above that, which are really important, which is, as I've said, how do we support patients in being active partners in this relationship? And how do we support caregivers so that they can bring their best self to that compassion interaction? There are 4 other domains. One I've touched on, which is lifelong learning about compassion. Compassion can be taught, communication can be enhanced. And so how do we do that? Like anything, we need to measure, value, and celebrate compassion. I'll talk a little bit about how we want to build compassion into healthcare delivery, a few examples there. And then again, the importance of leadership in fostering a culture of compassion. So I want to just touch on a few key components in each of these domains as I wrap up. So for patients and families, the most important thing there is to really understand fully the patient and family's needs, concerns, goals, and their individual preferences. It's really the whole person view of the individual, and providing that emotional and psychological support as well as the clinical support. And something that's very near and dear to my heart is making sure that we're always including the patient's loved ones, what I like to call the critical care partner in the process, because no patient can navigate the system by themselves these days. In the caregiver support domain, I think the good thing is that the roadmap for creating well-being programs has been really well established, and those programs need to include each of these components that are listed, including addressing any systemic drivers of burnout. Stress first aid clearly fits into this bucket as one of the programs that we are helping institutions roll out. In terms of promoting lifelong compassion learning, as I said, it's really important that we start this during early curriculum, during education of healthcare providers. And that's often where it's happening. When it's happening, it's often there in medical school. It's much less common than to have it during residency or internships, and even less likely to be happening when you're a faculty or attending or practicing a physician. The same, I believe, is true for the nursing or other disciplines. There's lots of opportunities to create lifelong opportunities to have this kind of discussion and reflection. And we feel like Schwartz Rounds is one way to create a reflective forum for storytelling and this type of learning. I'm a big measurement guy, have been throughout my career, and so it's really important that we think about how we actually assess patient and family perceptions of compassion. In a perfect world, this would be more explicitly embedded in some of our national satisfaction surveys. But also thinking about ways to align other incentives to reward compassion and really recognize individuals and best practices around compassion. I wanted to share this study that I have discovered in my onboarding, and that was back in 2014, a study entitled Compassion Practices in HCAHPS. Does rewarding and supporting workplace compassion actually influence patient perceptions? So this study was structured by surveying about 600 United States hospitals, a random sample, and asking their senior leadership to describe what they do in these five categories. Three of these really are around recognizing and rewarding compassion, and the last two are really how do they support frontline staff in a compassionate way. And what was striking is the study showed that in all of the regressions, that the compassion practices remain strongly, significantly, and positively associated with the HCAHPS outcomes that many folks are trying to improve, which is the overall rating score and the likelihood to recommend. And that was after controlling for many, many other known drivers of HCAHPS scores, which are listed here. So if you really want to focus on driving HCAHPS as one of your primary goals, there's a lot of evidence that would say that there's benefit. And then this next domain is about building compassion into healthcare delivery. And I like to think about this as both retrospective, thinking about we've made a change, it's a new model of care, and thinking about what has been the impact on compassion. But increasingly, how do we think about that prospectively? I use hospital at home as a great example as I've talked to various leaders in Massachusetts about this. We have certain things that we've studied as really positive outcomes. Could we do a deeper dive on what's this model of care actually meaning for the patient and family? And thinking about new innovations and models of care. There's probably no better example of that, and I think this is such a rich area for us over the next 5 or 10 years, than artificial intelligence, right? So I titled this slide, Will Compassion Survive or Thrive in the Era of Artificial Intelligence? So these are two, I think, provocative things that I pulled off of the internet recent research. The first was a study that looked at actual patient questions that were posted to a social media blog that were responded to by actual physicians. And then retrospectively, ChatGPT chatbots were asked to answer the same questions. And then those answers were compared in a blinded way by evaluators. And overwhelmingly, the chatbot responses were preferred over the physician responses and were rated much higher in terms of both the quality of the response and the empathy. And this study has been subsequently replicated across other disciplines and specialty areas. This is not a one-off finding. The other thing I noticed when I was doing preparation for this was the amount of work developing robots and how robots can be optimized from an empathy and compassion perspective. In this case, it's a humanoid robot interaction, this particular study. And I just wanted to read this couple of sentences. It says, effective communication is crucial for robots to be seen as caring, necessitating advanced mechatronic design and natural language processing. This paper examines the potential of humanoid robots to autonomously replicate compassionate care. I just thought that was an amazing, striking couple of sentences. I think it's reflective of the future. And then finally, like everything, I think every talk I've ever given on any topic related to quality and safety is really emphasizing the importance of leadership and the culture, right? And there's an evolving body that defines compassionate leadership and a culture of organizational compassion. And these are some of the aspects of those domains. There was one other study by Dr. Lown that I wanted to cite from 2017. And that was to look at the caregivers' perceptions within an institution of the extent to which they felt like their own institutions valued compassion. And that showed that that perception actually drove or was associated with their own compassion and their commitment to the organization. So those workers with higher perceived compassion rated their individual scores more highly, rated their commitment to their hospitals highly, and reported less turnover. So the point here being that organizational level compassion can really translate down to individual providers in those institutions. And then finally, as I wrap up, there's a lot more here in terms of our model. We have posted our model on our website. The link is shown here. This will be in the slides that we share afterwards. So you can read and learn a lot more about what we mean by each of these domains. I also have provided here a link to a new website or web page that we created called Evidence in Action. And here we're trying to answer that question of why does compassion matter? What's the proven benefits? So there's a document called that, The Case for Compassion and our ROI. And there's a much more elaborate description of our Schwartz rounds research if you want to dive into that. And today I want to just end by returning back to where we started as we celebrate our 30th anniversary. And that is to share another quote of Ken's, which I find really compelling. And that is, in addition to everything that we've talked to at the team level, system, kind of organizational level, we're still left with the power and the importance of that individual, one patient, one provider, or one team, and that relationship. And as Ken said, I've been the recipient of an extraordinary array of human and humane response to my plight. These acts of kindness, the simple human touch from my caregivers, have made the unbearable bearable. So it's been my great pleasure to come in as a leader of this wonderful institution and try to advance compassion across the state and the US and around the world. So at this point, I'm looking forward to discussion and questions.
Thank you so much, Dr. Gustafson. We really appreciate it. I can't thank you enough. So we're opening up to questions. So if you have one, look at all the accolades you're getting, which is great. Please feel free to raise your hand. We do have questions that were put into the chat. Jackie will take that, and whoever, when you raise your hand, we'll take that one first. Jackie, I'll take this one, okay? Okay, I think Kevin.
Good afternoon, everyone. Thank you so much for this brilliant presentation, Dr. Gustafson. I've tried to, everyone I know that also works in human services, I have tried to also promote this workshop. I think it's so important. Thank you, and to the Betsy Lehman Center. May I ask Dr. Gustafson, toward your opening remarks, where you talked about trying to, promote this model and this support sort of web of concepts and practices. Further, have you been able to engage the Carter Center as well in their extensive work? I'm sure this would be something of very high interest to them.
Kevin, thank you for attending today, and thanks for the question. I'm afraid to say I'm not familiar with the Carter Institute, but I have tried to do a lot of networking around all the other organizations that are doing work in this space. So I'd love to learn more.
So
Okay.
Kevin, you have to know that Dr. Gustafson has people on this call, and they're writing down things. So if they're not connected, they will be soon. So
Wonderful.
thanks, Kevin.
And if I can help with that, thank you, Linda. Always great job facilitating.
Okay, if he needs help, we'll get in touch. Okay, Kevin, thank you. Jackie?
Thank you, Linda. One question we had in the chat is, how does one build administrative compassion for healthcare professionals? Administrative overriding of professional autonomy is a great stress inducer.
Yeah. It's a great question. I think there's still a great deal, I think, education to be done with healthcare leaders around many of the topics that I covered today. One of the things we're trying to do is specifically create materials for our champions who are having these kind of discussions, right? How can they advance a well-being agenda? How can they advance the importance of compassion with the decision makers in their institutions, whether that's CFOs, CEOs, the other C-suite leaders? So I think it's crafting that message around this importance, and then breaking down the components. So I think that specific question is around well-being and burnout, right? And we know one of the components of that is system drivers of burnout and the sense of autonomy and control. And so I think those are really tough issues to crack with an institution, but having an open discussion that they are impacting providers, that it is impacting their well-being, their decision to stay and be productive is a starting point. Oh,
Sorry, if anybody else wants to ask questions, please raise your hand and we'll.
We also got some questions that folks had sent in before this training that I could read one while people think of a question. So
That's
one
great.
question that we had was, what steps can providers employ to advance compassionate care to patients while balancing their own self-care?
yeah. Great question. I think both are really important. That's the first thing I would say in response to that, right? It's a very common theme now in caregiver well-being that providers need to take care of themselves at work and outside of the work so they can bring their best selves to the bedside or to the care setting, and acknowledging that's really important. And then thinking about what are the different ways, the simple things that are under the control of an individual, right, that can impact that interaction with the patient. I think a lot of times we get caught up in that there are macro drivers and systems issues. End of the day, there is in front of each provider is an individual patient interaction. And so just remembering the humanity of that person in front of us, trying to understand the full person and all their issues and needs, and not underestimating the value of just listening, a minute of listening or a simple human touch. These are the importance of the little small moments of compassion that make a tremendous difference. And those are very doable, right? Those aren't macro rocks that need to be lifted, but there are things that are under control, each person's control.
Thank you. That is well put. And as a frequent flyer, I know those little things, when people take time, mean a tremendous amount. I want to ask, I don't know if we have any more questions. Jackie, I'll let you look at the document for another. My question is, I find it's easier to do this work until something goes wrong. And then I think people freeze. How do you keep them continued on this when that happens? And you know my story, so I've seen that over the years. I would love for that compassion to continue to happen even when things don't go according to plan.
Yeah, meaning like when an individual patient has a bad outcome or an adverse.
Yeah, exactly.
Because as you and I have talked many times later, so sometimes the reaction is the team to pull back or to be afraid to have a conversation, and it starts to further undermine how the situation might be dealt with, right? We had a wonderful webinar last week, actually, and it was around how patient feedback can be used to improve communication. And this their presentation was around improving adverse event. So it was a training program for students and residents when an adverse event happens, how to actually lean into it, to actually have the discussion. And the reality is, adverse events are rare occurrences. Folks are not trained how to do it. They may see one, but but it may not be the best model. So the idea is, how do you actually practice and prepare in advance of when you actually need to have these types of difficult conversations? So that was a brilliant kind of application of communication training.
Mhm.
If they applied to adverse events. It's so important.
Thank you. And I love that idea of leaning in instead of what I think all of us, our reaction is to run, but the idea of leaning in even when it's uncomfortable and teaching people how to do that. So thank you. Jackie?
Yep. I'm going to read another question. What would be the one piece of advice you would offer a provider who's working on increasing or showing empathy and compassion in their communication skills?
Wow. That's tough. There's so many things I could say, but one thing I would start with is probably just listening, right? Both from my own experience with myself or my family members, listening is so important, and it's a great start to a relationship. I think often that's the essence of training around communication. The first step is actually giving the patient the chance to express what's going on and to listen. So, you know, it's been shown by studies that often it's only within 15 or 20 seconds that most providers interrupt the patient, right? Because they're rushed, they're anxious, or they want to move on to what the topic is. So I guess if I had to pick one thing, I would start there. I think the other is not to underestimate the body language and I'm old-fashioned this way, but that interaction, um, it's the it's the connection with the face, with the eyes, it's the human touch, it's the posturing that really conveys a sense of compassion, right? So it's how you're presenting it in the room to the patient as well as what you're saying.
You for that?
I just want to say thank you. My kids are millennials and they look at their phone all the time, and I had to teach my youngest, when you're talking to somebody, you got to look at them in the eye so they know that you're listening. That took a long time to get her there, but she's 30 and she's there. But I do feel like, are there generational differences in this work? Have you, as the Schwartz, noticed any of that?
It's a great question, Linda. I'm not I haven't seen literature and I can't really speak to that. I think the examples that you mentioned might be kind of applications, but I haven't identified any literature that kind of is specifically defining compassion characteristics across the different generations.
Thank you. And okay, do you have a question, Jackie?
Yes, so we have two questions related to the Schwartz Center that I'm gonna try to combine. So one is what differs the Schwartz round from other forums or rounds? And that part two of that is, does the Schwartz Center offer skill-based, skill-building practices like listening, empathy circles that can help practitioners build their own empathetic muscles?
Yep.
Great question.
Great, thank you. So I think the key thing that distinguishes Schwartz rounds is that it's not a clinical based discussion and it's not a problem solving discussion. If you think about the other forums that we have in hospitals, so a grand round session, an M&M, a root cause analysis, a adverse event debriefing, it's often focuses on the clinical decision-making process and the root cause and the problem solving, right? We want to get to solutions and fixing things. So that's one of the things we have to be careful that the discussions in Schwartz rounds don't gravitate to that because there are other forms for that. This is really focused on the human emotions, the emotions of patients, families, and the emotions as caregivers, both the positive and the negative. It's also very, I don't know if it's unique, but it's very unusual to have such a non-hierarchical, multidisciplinary clinical and non-clinical audience. Like you can literally have the president of the hospital and surgeons and front desk staff and nurses and therapists, et cetera, sometimes all on the panel presenting on the same topic, which is really extraordinary. And it has all of those ripple effects of breaking down the hierarchies, demonstrating leadership. The other thing that is really unique about Schwartz rounds is it's this space it's what we call a countercultural space that's created. And the biggest part of that is demonstrating vulnerability, right? As many of you know, in short rounds, it's often a very emotional setting. It's not unusual for staff to cry. It could be the most senior physician in the organization sharing a adverse event story and breaking down because even though it was 20 years ago, it still is heartbreaking to them today, right? And so that modeling of vulnerability is really important because that has the ripple effects of demonstrating the right culture in the institution of trust and psychological safety, so that those discussions can happen outside of shorts rounds, right? That's the ripple effect, because you're demonstrating and modeling and mentoring that type of behavior. The right now, for example, we have a compassion cultivation training program that's based out of the work at Stanford. We have a trainer that was done there. That's an individual self-compassion and resilience building program. We're looking at in the future developing some other programs that might be aligned with what the questioner was asking about.
Thank you very much. I think there might be some ways that our work and your work can move further along. So I will talk to you about that after. But somebody did say they would love to see your work in veterinarian schools and stuff. So I didn't know if you saw that. So
yeah, Linda, just to comment on that, what we have discovered is that, first of all, in the United Kingdom, our partner there who does shorts rounds has piloted running these exact same shorts rounds with both veterinary schools and with veterinary practices, and have actually published. So if you Googled shorts rounds of veterinary, you'll find a couple of articles that have been written about the profound impact. The important thing is that the data for suicide, anxiety, depression, burnout, leaving the profession is as great, if not greater, among veterinarians in the UK, nurses and techs. And I think it's we're finding it's equally true in the US as well. And so we're really excited about trying to extend this intervention to the vet setting in the United States.
wow, amazing. That's great information. We have some other questions. We'll just keep those. I want to thank you so much. I can't even tell you. I learned a tremendous amount, and I thought I knew stuff. And I was part of a couple of Schwartz rounds, but I've learned so much. And you guys have expanded your work. I want to say thank you. I think Whitney put in a survey about this presentation in the chat. If you could please fill it out, it helps us decide, you know, who we're picking for you to hear and who you'd like to see in the future. We will be sending in the next day or two the recording of this presentation along with Dr. Gustafson's slides, and then any other resources that that we get from the questions that are going in the chat. Thank you so much. Barbara, thank you for staying. I thank you, Kevin. If he needs any help getting in contact, we'll be in touch. Okay.
Thanks so much. Brilliant,
Okay.
brilliant work.
Thank you. Thank you.
Thanks, everybody.
Thank you very much.